Welcome to the body imaging cases. This is a 54-year-old lady with repeated attacks of epigastric pain and vomiting since 2003. Contrast-enhanced CT showed two structures instead of one at the gallbladder fossa. The anterior part is A, the posterior part is B, and it is clear that this is not a gallbladder that is folded over itself. There are two structures here. On ultrasonography, the anterior structure contains echogenic material and has a thicker wall, while the posterior structure contains clear fluid and has a thin wall. And on MRI, the anterior structure shows less strong signal intensity than the posterior structure on this T2 weighted image. And the same is on the MRCP. The difference between the two structures is more obvious because of the heavily T2 weighted image. On the fusion weighted images, the anterior structure shows restriction of the fusion of its content and of its wall, while the posterior structure has a very thin wall and does not have diffusion restriction of its fluid content. So, to explain this, we have two scenarios, either to say that the posterior structure is the gallbladder or the anterior structure is the gallbladder. Considering the posterior structure to be the gallbladder, we have here the common bile duct, cystic duct, and gallbladder, and then the structure which sits at the fundus of the presumed, between brackets, gallbladder could be one of four things: either a duplication cyst of the gallbladder, infected Rokitansky-Ashov sinus in adenomyomatosis, ciliated foregut cyst of the undersurface of the liver at segment 4 and 5, or a hydatid cyst also projecting from the undersurface of the liver at the segments 4 or 5. Considering the anterior structure to be the gallbladder, then the posterior cystic structure should be a dilated cystic duct, in this case a choledochal cyst of the cystic duct. But let us first trace the common bile duct down and to see if we have more observations in this case. That's the common bile duct here, and here it reaches the ampulla of Vater, delineated by the orally administered contrast agent in the duodenum. But here we see a structure to the left of the vertical part, the second part of the duodenum. This structure pointed to by the yellow arrow contains gas and oral contrast agent, so presumably this is a paraampullary diverticulum of the duodenum coming from the junction between the second and third parts of the duodenum. That's a typical appearance. And here the green arrow again points to the third part of the duodenum as it crosses at the aortomesenteric space. So from here we'll go up again with the fourth part of the duodenum, and we will encounter more diverticula. This is a diverticulum coming from the fourth part of the duodenum, pointed to by the yellow arrow. The red arrow shows inflamed mesenteric fat. This is dirty fat of the mesentery. And we see another diverticulum now coming from the jejunum, and one more diverticulum coming from the duodenojejunal junction. Still we see the red arrow pointing to the dirty fat around these 3 diverticula, which means they are inflamed or perforated. Probably perforated is the best expression, because the red arrow here points to a gas bubble within the mesenteric fat, extraluminal. And here is another one. So we have 3 diverticula here at the duodenojejunal junction. One of them is perforated, probably all of them inflamed. And this is a 3-dimensional representation of the story. We see the stomach, the first part of the duodenum, and the red color here represents the oral contrast agent. The blue color represents gas. So this is the gas bubble of the stomach and the gas bubble at the first part of the duodenum. Then we come to the second part of the duodenum, and between the second and third part of the duodenum we see the para-ampullary diverticulum, and at the fourth part we see 2 diverticula, and at the jejunum we see 1 more diverticulum. Rotating the frame, we can appreciate here the gas bubble, the extraluminal gas bubble, which denotes perforation of one of the diverticula, probably the one sitting at the duodenojejunal junction. So the patient has been operated upon, and this is a photograph during the operation of the gallbladder and the cyst related to it. The structure A is the gallbladder, and the structure B, you notice that it has a different color, and for the surgeon's eye this different color means that the structure P is devoid of its muscle coat, of its muscle layer, and that's the reason why its color is different. So structure A was identified as the gallbladder, the inflamed gallbladder, and the structure P is a choledochal cyst of the cystic duct, which connects the gallbladder A to the normal part of the cystic duct C. And this is a diagrammatic representation of this surgical view. So during the operation, the jejunal diverticula, the one which has perforated, has been also removed, and this fused image of the CT showing the upper gastrointestinal tract and the MRCP showing the bile ducts and the gallbladder are fused together, and here you know why the gallbladder has been inflamed. It is because we have 2 inviting factors for inflammation: the para-ampullary diverticulum and the rest of the duodenal and jejunal diverticula, and the cystic duct choledochal cyst. Both of these structures will invite infection because of the stagnation of their content. So we assume that an ascending infection may go up through the common bile duct, and there will be stagnation again here in the region of the cystic duct choledococele to the gallbladder. So what happens here is that the gallbladder opening into the cystic duct choledochal cyst has been occluded, and therefore we see the different types of fluid within each of these structures on ultrasonography, on MRI, and on CT. And that's the reason why this patient has been suffering since 2003 from the repeated infections caused on one hand by the diverticula and ascending infection to the gallbladder, and on the other hand the stagnation of bile in the choledochal cyst, which is devoid of muscle wall. So the diagnosis here is acute on top of chronic cholecystitis, which was found at histopathology to be xanthomatous, and choledochal cyst of the cystic duct with multiple duodenal and jejunal diverticula. The case illustrates the coexistence of two types of lesions, both of them inviting infection: a choledochal cyst limited to the cystic duct, which is a rare type of choledochal cyst, and paraampullary duodenal and jejunal diverticula. Both types of pathology are risk factors for infection because of the stagnation of their contents. And finally, choledochal cysts have deficient muscle wall, which is recognizable during surgery.